So that's 30,000-foot view. Now I'll sort of dive into some of the study data to see, do any of these dosing regimens work better than any other dosing regimens? So, we've had a couple of comparison studies come out between Lucentis and Avastin. Just got to give us a summary of some of those studies.
Yes. Jason did such a great summary of the different dosing regimens, and I like to break them down between proactive and reactive dosing. Do we wait to see vision loss? Do we wait to see thickening on OCT before we intervene? Versus a fixed dosing regimen like we see in View 1, View 2 first year, the CAT study, the 2 arms with monthly dosing, or even Marina and Anchor, fixed dosing regimens. And I think many of the studies that you're referring to help tease out differences between these dosing regimens, what works and what doesn't work as well. But the CAT study, for instance, provides a wealth of information about monthly Lucentis, monthly Avastin versus both of those as needed. And at the 2-year mark, it's very clear that as-needed dosing regimens do not fare as well. That reactive dosing regimens, waiting for fluid to occur, waiting for vision loss, and then treating, they don't seem to do as well. View 1 and View 2, for instance, in the first year, when you have a distinct proactive fixed dosing regimen, the patients did very well, and whether you use aflibercept or ranibizumab. But in year 2, when we shift over to a reactive dosing regimen, there's a slight tapering off of vision. There may be 1 or 2 letters, but there's a distinct difference in year 2 compared to year 1. So just based on an efficacy standpoint, I think the trials that you're speaking of, they do lend support to a proactive dosing regimen. Fixed dosing regimen may have benefits, and it's very interesting to point out that Treat and Extend is a proactive dosing regimen. That it takes a lot of skill, and that's where we practice the art of retina, to customize the treatment for a patient's eye to really understand what is that dosing interval for that specific eye in that patient. But it is proactive. We don't wait for the fluid to recur. We don't wait for vision loss. We treat before that happens. And if you look at the ASR's PAT survey, Treat and Extend is a very popular regimen that many of us use.
Justice.
The interesting thing about Treat and Extend is I would categorize it as a proactive reactive regimen. It's in that you are being very proactive in maintaining the dry OCT, but at the same time your goal is to increase the interval in between, and ultimately you almost are extending to the point where they do recur. So there is an element of reactivity to it. One of the questions that it'll be interesting to see. Treat and Extend has a lot of pros from a treatment burden, from a patient burden standpoint, from an anatomic standpoint. The challenge is we don't have as much data on it. And one of the questions in PRN is, what's the reason for loss? Is it chronic fluid that keeps reacting, or is it catastrophic vision loss in some eyes because they don't have anti-VEGF on board? And does Treat and Extend change some of those catastrophic changes? And that'll be interesting to see over time how those things pan out.
So, you are at the Cole Institute. You hear about CAT on a daily basis, oftentimes when we don't want to hear about it. And, one of the things that Dr. Martin, I think, stresses, which I find odd, because I look at the CAT study and I would agree with you, the PRN arm did not do as well as monthly. But if you listen to Dan give lectures about sort of the top things that he thinks you should learn from the CAT, he actually doesn't say that. He's more positive about as needed. Why do you think that is?
Well, I think it's because it was the first trial to really show pretty good results with PRN. I mean, at 1 year, the Avastin comparison at PRN was inconclusive, but ranibizumab PRN was essentially equivalent. Now, at 2 years was when it starts to fade. One of the most interesting things coming out of CAT, I think, at the 2-year data was when they split the groups up. And you went from treating monthly for the first year to PRN regimen in half the groups. And they went almost very quickly down to the PRN level of vision. Again, it's not a huge difference between the two groups, but it does beg the question, in a chronic disease, how long do you do this for? Can you do monthly treatment on label? And you certainly can. Will our patients allow us, to do that? And that's where things become really tough. And I think it's why all of us try to individualize treatment in a lot of cases, because this is a 4-year, 5-year, 20-year disease, and we only have data to 2 years. And what we see is at 1 year, yes, and 2 years it's better. And then that also begs the question, are lines diverging? So if you stick with PRN at 5 years, are you going to be even worse off? But I think that's part of it, is that it was really one of the first studies to show that PRN treatment at 1 year with essentially zero tolerance to fluid and very close following, it does do well. It doesn't do quite as well, especially at 2 years compared to monthly.
And I think it's important to point out that PRN in the CAT study was very different than PRN in all our previous studies. The criteria to treat was much more stringent.
Yes.
And you needed monthly monitoring. The patients had to come in every single month for an examination. So PRN in CAT study was very different, and probably one of the only studies that showed in first year that as-needed ranibizumab was not inferior to monthly ranibizumab. But the other perspective I'd like to point out is OCT drying, that really the monthly dosing regimens did better in terms of drier retinas, especially the ranibizumab monthly. But once again, just to reinforce what Justice was saying, that the arms start to separate by year 2. And at the end of year 2, my understanding of the data is that ranibizumab monthly did better than the other groups. Not much, but it did do a little better than, especially the PRN.
From an OCT standpoint.
Yes. And,
Well, and it's interesting. From an OCT standpoint, in the Lucentis monthly from CAT, they actually, if you look at the average retinal thickness, were thinner than normal.
Yes.
What do you make of that, Jason?
Well, I think, first of all, look at the OCT systems that were used. I always caution that, remember, we were time domain in CAT, and I raise a big red flag about that, both from a positive and negative point of view. I don't know how much we can rely on the thickness measurements in the time domain systems. I have to, we all discussed earlier the limitations. Had it been a spectral domain system, which wasn't available at the time, we might have very different information. It will be very interesting to see how that plays out. Other studies have looked at that, and some of the other studies of other drugs have employed spectral domains, and we'll be able to look at that as those new data become available. Certainly the thinning is an issue, and that goes directly to the issue of whether there's too much VEGF suppression, whether you can have too much of a good thing, whether you can cause choroidal vascular changes, whether you induce atrophy. I don't really know yet. I'll have to be honest. The data from CAT is at best inconclusive. It is definitely not convincing yet that there is indeed an issue with regard to atrophy, and I think analyses of some studies that have used spectral domain will actually tell us whether or not there really is an issue with atrophy in these patients. I just want to go back to the other issue of the CAT study, and that is that PRN might have fared better had we had spectral domain, because we don't know what we were missing.
Right.
So it's interesting that it was successful in the first year to be fairly close, and it slipped. And the question is, if you were missing 10 or 20% of your patients with fluid, and they had even a small amount that would have been picked up with spectral domain, and had that been applied in the PRN arms, would they have been closer?
Right.
And in fact, would PRN have fared much better had we truly known if there was leakage?
Well, and that's what, it did change. When the CAT data came out, it changed my management for the patients who I was treating in a PRN regimen. Some of them it's difficult after 18 months of treatment and doing well to say, I want to see in 4 weeks. But after watching that, I realized that's the way to do it. That's the only way that really you can be comfortable with that regimented follow-up to do that. And but the spectral domain, time domain question is very interesting because the numbers of, amount of fluid and percentages that were missed by the investigators compared to the reading center was quite high.
Well, and your reading center read the Harbor data set, which in a way mirrored part of CAT in that
Yes.
you had Lucentis both monthly and PRN, but
Correct.
used spectral domain OCT. Is there anything that you can enlighten us from the Harbor data about PRN versus monthly?
Well, not much that's out there at the moment, I guess I would have to say.
Okay.
So there's some limitations, but we'll hear more about that going forward. But having looked at that, I can tell you that the ability to identify very tiny bits of fluid, and again, we're learning more and more that these intraretinal cysts may be important. The very subtle findings that time domain would easily have missed in the methodology that was used may be very, very important, and that's part of what's going to be pulled out now from the Harbor study, is to look at that detail as well as other factors that are going on that you can really identify with spectral domain that couldn't be done before.
One
Yeah.
quick,
Go ahead.
just a quick comment on like PRN dosing for like almost all the studies. They had very strict criteria. They're like it had to be greater than 50 microns of thickness. It had to be like X, Y, and Z. Whereas if you saw the patient in clinic and you're like, okay, well, it's 20 microns thicker, but I can see that there's some fluid and cysts forming. I'm not going to wait another month to have you come back. I'm going to treat you that same day. So PRN it's so regimented that it's almost like they're getting worse, but you can't do anything because you're bound by the study entry criteria and guidelines. So I think a treat and extend protocol kind of is a hybrid between the two, which might possibly get the best of both.
Yeah, and I think you all bring up a very important point, which is, we read these studies and we look at PRN, and for instance, in the Ivan study, the PRN group was totally different, right? They did this continuous versus discontinuous, did 3 injections instead of 1, and that one didn't show as much of a difference, and we'll have a primary outcome, shortly here at ARVO. But I think one thing that's missed, especially if you look at sort of like Medicare utilization data for macular degeneration, is I don't think the general public is actually doing the PRN that was done in clinical studies. They go, well, PRN works pretty good, then I'm going to do it, but then they see patients at like 3-month intervals, but do PRN at 3-month intervals.
Right.
So I think there's sort of that disconnect, and it's very important to understand if you're doing PRN to really, you need to see the patient very frequently for PRN to be beneficial. We'll have some results on treat and extend in the Lucas study, which is the only randomized study going on that's looking at treat and extend. It's also a comparison study, and that should be coming out, I think, later on this year. So it's not too far off that we'll have at least some clinical trial data on treat and extend. So we talked a lot about CAT. There were 2 other studies. Ivan, MANTA are 2 other studies comparing Lucentis and Avastin. Did they show anything different from CAT?
So in general, in terms of the one, as you mentioned, Peter, the primary endpoint for Ivan was at 2 years and not at 1 year, and we're going to, I think, on Tuesday here at ARVO, hear those results. MANTA and Ivan both showed essentially similar findings, as from a trend standpoint, that the 2 agents have similar visual acuity results when compared. And in general, there's some trend towards or significance, depending on the treatment arms, for Lucentis having more of a drying effect on the OCT. The safety signals, also is something that's gotten a lot of discussion. We didn't talk about that with CAT. Each of those other trials were much smaller, and none of these studies are powered to actually find these rare events. CAT had around 1,200 patients, Ivan had around 600, and then MANTA was around a little over 300 patients. And the interesting thing with the MANTA study was in both CAT and Ivan, Lucentis, although again a lot of times was not significant, tended to be just a little bit above with the absolute values. In MANTA, it was flipped, and it's the first one that's come out where Avastin was slightly above, again not significant, in comparison with Lucentis.
Yeah, it was a very interesting finding, and we'll be hearing some more comparison studies as they come out, and hopefully with a meta-analysis, we can really see this. I mean, if you had to just say a 1-sentence sort of summary of the comparison studies to date, talking about just efficacy of Lucentis versus Avastin, Jason, what would be your 1-sentence summary?
I think that if you use the drugs monthly, they behave very similarly, and when you start to apply them in an alternate treatment regimen such as PRN, there may be differences that are important to the patient, with Lucentis behaving better than Avastin on the PRN basis. And overall, again, as we've seen time and again, regular monthly treatment from a visual standpoint gives the best result than anything we've done to date in clinical trials. And that's why the results of the treat and extend type studies will be important, because we need to see whether that holds.
There's a lot of commas in that sentence.
Yes.